Please, I would like to invite our speakers for our last questions and answers, please. As I said, we have lots of questions, so I'm going to start with one of the most voted one. It's for Dr. Williams and Dr. Skłodowski. What's your clinical plan when you have an idiopathic skinny old cat? Curious what will you do when no diagnosis is found from a medical and nutritional perspective.
Can you say the second part of the question again? What?
The person is curious about what you do when you have no diagnosis found for the weight loss or for the skinny cat, for the clinical and nutritional perspective. I think it serves for all of you.
Well, I mean, I start out by doing a GI lab panel. That's what we call it anyway. It's a serum TLI, PLI, cobalamin, and folate, just as a minimum database. That's assuming you've done a routine CBC in a panel and there's no kidney disease or evidence of liver disease or something else. So my first thing is to look for evidence of GI disease, knowing that the cobalamin and folate are not perfect. It's an easy thing to do. And there's some data that about 30 to 40% of old cats will have a low cobalamin if you look for data from IDEXX and people like that. So you could certainly argue that that's part of good old cat management. And if you find an abnormality, then you've got a GI disease that you can think about pursuing or treat presumptively depending on the circumstances. So that for me, that's a routine thing for a cat that's 10 years of age or so.
Yes, it's more and more common in our routines. Very well. How do we boost, it's for Dr. Skłodowski, how do we boost Clostridium irionanis? Is there an effective probiotic formula with it? If not, how can we address it nutritionally?
So you cannot really, so I think it's important to understand why we have a dysbiosis, okay? And so what we are thinking, the best evidence we have now is pretty strong evidence, very consistent, is either prior antibiotic use or is chronic GI disease. And so when you have chronic GI disease, it's a multimodal approach. You cannot specifically increase or change, because the change is so drastic, it's a huge change. You have to look at the microbes and the huge ecosystem. It's not easy to just simply, plant a few plants. It's changing the whole underlying GI structure, which obviously with all data together, we cannot. It's a long-term process and so on. Now I think fecal transplant is now an option that more and more we're kind of getting comfortable with. We can actually bring coronaries back with fecal transplants. Often it correlates pretty well with improvements, but because the underlying GI condition is still abnormal, the dysbiosis is going to keep coming back. And so it's, again, always coming back to the same principle. It's a long-term destroyed system, and we're managing everything. We're going to manage with diet, with everything. But it's also important not to chase the dysbiosis. The dysbiosis is just one part of the whole disease process. That's important.
Good, very good. Another good question. Some dogs with acute or chronic diarrhea appear to have rapid improvement in stool quality with metronidazole. What's the mechanism for clinical improvement despite negative impact on other parameters? I'm trying to explain to those who use metronidazole because it appears work.
I'm happy to answer that. I think the simple explanation is if you give antibiotics, you're going to reduce total bacterial load to some degree. So the less bacteria you have, the less immune system stimulation you're going to have. And if that's important, that can work. But the problem with that is that at the same time, you're inducing a dysbiosis shift. And so the question is it really a benefit? In acute diarrhea, I think there's plenty of evidence now that antibiotics are not really accelerating the recovery of the GI disease itself.
Compared with placebo.
Compared with placebo, compared with digestible diets and so on. But that's the principle.
Good. Another one, it's a million question. Can Dr. Williams speak about its recommendation to decrease carbohydrate in geriatric cats or cats with chronic enteropathy?
Speak about it from, well, the reason that I think it works is that we know from old work that cats have relatively low amounts of carbohydrates, maltase, sucrase, and lactase in their small intestines, and they have an awful lot less amylase in their pancreases than dogs do. And when people and cats get small intestinal disease, it's the disaccharidases that get knocked off first. Disaccharidases hang out in the gut lumen on a stalk, and bacteria, as in increased bacteria with dysbiosis, are known to be very good at knocking off maltase, sucrase, and lactase. So I don't know that anybody has proven this, but it's a traditional thing that cats can become deficient in carbohydrates quite quickly, which is why cats sometimes get diarrhea when you give them milk and dairy products. It's not because they're sensitive to bovine proteins. They just can't handle the lactose that's in those types of diets. So the logic is to take away something which the cat with a sick gut is not as good at digesting as a healthy cat. And I've been told by people in the pet food industry that cats on a high protein, low carbohydrate diet, that their stool scores will actually firm up pretty well across the board. And again, I think that's because you're taking away something that will not be 100% digested and absorbed, so it sits there and it might exacerbate a dysbiosis-related effect.
Yes, amazing, very good. Is there any data on effect of neutering in dogs and cats and the risk or prevalence of sarcopenia? Is there any data on effect of neutering in dogs or cats and the risk or prevalence of sarcopenia?
Not really.
No, not at all.
Unfortunately, that's
Yeah.
that's where we need to go. That's a direction that we really need to focus on.
Okay. Let me check this one. Neutering, enteropathy, Clostridium rhamnosus, acute diarrhea, and dysbiosis. We have lots of questions. What's the benefit of providing dietary protein versus increasing activity for building and maintain muscle mass?
Well, I think they're largely complementary. On the one hand, the activity will just trigger the anabolic signals via the local contraction, so the intracellular mechanisms in the muscle fiber. The dietary protein will do two things. Will bring the building blocks, the amino acids that need to be incorporated, and then, as was explained, the anabolic amino acid, the branch chain, will stimulate on top of that the mechanisms for muscle protein synthesis. So it's largely complementary mechanisms.
Yes. And another one of Clostridium rhamnosus is the start of the morning. Is there any associations or studies about Clostridium rhamnosus levels and fat content or types of fatty acids in diet?
Not that I'm aware of. I think it's interesting that Clostridium rhamnosus is a very tightly regulated bacterium, so it doesn't really change that much. It's in the normal range, is quite rare, so I think it's either normal or abnormal. It's difficult to also have those associations because usually when it's decreased, you also know that you have GI disease and malabsorptions, loss of fatty acids, so I think it's difficult to separate those two out. It comes from the malabsorption, it comes from the dysbiosis pattern.
Good. One more about dysbiosis in gastrointestinal microbiome. When considering the gastrointestinal microbiome and dysbiosis, how important is it to consider the microbiome in different regions of the gastrointestinal tract rather than in the gastrointestinal tract as a whole in trying to identify dysbiosis?
Yeah, that's a great question. Now, obviously, the GI tract is a long and winding like a river, so we're not going to catch every single change. And traditionally, we always thought that the small intestine is the most important one, like as one of the dysbiosis. And I think what we can see in a fecal sample, we still can see if there's a change in the gut microbiome. So, what happens even in the stomach with omeprazole, we can see in a fecal sample. What we don't really see really well is if there's attached bacteria to the mucosa and so on, and if there's increased numbers. But generally, that's the limitation of it.
Good.
Yeah, I have a comment about that as well. I think it's a whole different world. And because it's so relatively easy to collect feces, and there are things going on there, people have forgotten that a lot of the original work that was done by Roger Batt in the United Kingdom was done on jejunal juice and the relationship between my PhD in EPI, the relationship between what's going on intraluminally and the jejunal mucosa. And there's actually a lot known about that, but people don't do that type of work anymore because it's actually really hard to get jejunal juice to work on. But it's a different place, and I'm quite sure there are things going on up there that are totally irrelevant to what's happening lower down. At the same time, lower down reacts to what's happening up top. So I think a lot of metabolic things can happen in the lower small bowel and colon because something's not going well in the jejunum. So it's an area that needs a lot of work, but I don't quite know how you work on it anymore when you can't even really get the samples very easily.
Just maybe like one additional comment, because this concept of small intestinal bacterial overgrowth, even in humans, they're moving away from it as being a pure bacterial overgrowth. There's still a huge overlap with inflammation, with underlying changes. So I think this classical, it's just bacterial overgrowth is probably rare. It's still this overlapping, inflammatory architectural changes, also in humans now.
I mean, there are some things like if you get a high serum folate, and it's not the most common thing, but even in cats, we sometimes see really, really, really high folate spontaneously. And to my knowledge, that can only be coming from the upper small intestine. It's hard for me to imagine that no matter how much folate you make in the colon, that you will absorb a lot of it. So when you see those sky-high folates, I think it has to be an upper small intestinal thing.
Very interesting. If muscle strain is a part of the sarcopenia diagnosis, how could that be assessed in dogs and cats?
Reassessing sarcopenia in dogs and cats?
But compared with human species where muscle strain is part of the diagnosis, how can we address this in dogs and cats?
It's possible with time, but right now we aren't at that level in terms of assessing sarcopenia. I think that will take obviously some research into it, whether it has to do with taking muscle biopsies from relation and investigating what's going on in those, looking at it from a omics perspective. But I think it can be a little challenging because getting muscle biopsies from dogs and cats when you're working in a clinical setting and trying to get that approved through our animal care and use or IACUC can make it more challenging. And so perhaps, instead of doing that, maybe they could look at some metabolomics to figure out if there's ways to take that information and relate it back to changes in the muscle in terms of fibers and things like that. But I think that we have a long way to go. I think the scoring that we do now, the assessment is very subjective, to be honest with you.
And still about the sarcopenia and Freud syndrome, are there any sufficient difference between sarcopenia and Freud to create a new classification? Are we sure they are different in dogs and cats?
I don't know. I don't know the answer to that. Can you just extrapolate information from humans and move it over to dogs and cats? Could you do that with frailty? Can you do that with sarcopenia? Body condition scoring, it's a little bit different. And so I don't feel I would be comfortable using the same exact scoring system, just from the perspective of, just the way the human is upright and moving and using different muscles versus the dog and the cat. And also the diet, the way we feed them is different, their environment is different. And all those things, from what we learned this morning, play a big role in muscle protein synthesis and degradation. So what that actually has to do with the scoring, I'm not sure, but and maybe nothing at all, but I just feel like that we shouldn't be doing that, one-for-one thing. I think we should be investigating it a little more from the cat and dog perspective.
Any comments, Dr. Williams?
I guess my question is whether anybody's doing anything more with the measuring ultrasound of muscle fat, back fat muscle, and back T4 fat and muscle.
There are a couple of studies, one Dr. Freeman did a number of years back and one that our lab did, of trying to identify through ultrasound specific muscle bodies that are, one, easy to determine their thickness in terms of using ultrasound, so it would be sort of a cage side thing. Also, I think that one of the reasons at least our group did it was because we found through the human literature and studies that that humans that are stuck in bed from being ill, that they can have a significant decrease in muscle mass within just a couple of days. And so we were trying to find an easy marker to look at muscle mass. We weren't looking at fat mass, we were just looking at muscle mass. And, you know, I think between our study and Dr. Freeman's study, that with time we can come up with something that's more universal and easy for clinicians to do in a hospital setting, and then correlate that with the degree of sarcopenia, and how to institute interventions. But we have some work to do on it.
It did appear from my limited reading that the advent of starting to lose fat seems to be a significant change. And certainly in the old cats, the Purina evidence would suggest that that is a marker for things starting to go downhill. Now, there probably are, as I think I talked about, speculation that maybe they don't absorb as much fat, so they start to break down their own body fat. And certainly there are metabolic consequences of digesting ingested food, which are different from the metabolic consequences of breaking down your own body fat. So there may be some, again, proxy markers that might indicate something is starting to happen, but that requires a lot of investment to find out what those markers actually might be.
I think along with that, looking at markers, I think that investigating some specific biomarkers of sarcopenia that we can, that we can easily get from cats and dogs without a lot of doing something super invasive would be a great idea in terms of directions for research. I know that some of the literature in humans starting to look at myostatin. I don't know how much of how relevant that would be in a dog and a cat in terms of diagnosing or scoring sarcopenia, but at least that idea might be a direction to do more research in.
We have an outreach question. Please, Dr. Laflamme.
This question is predominantly for Dr. Saker. So there's a handful of studies in dogs and cats showing that with age, obviously they lose lean body mass, and feeding them a higher protein diet actually slows down that loss of lean body mass. AFCO, FEDIF, NRC, they don't have any guidelines for the senior pet diet in terms of those nutritional profiles. So your extrapolation from the humans is consistent with the published literature, but it is not consistent with the standards, if you will. If you look at commercial pet foods, senior diets, of course, are all over the boards. There's no such thing as a senior diet. It's whatever company wants to do. For decades, certain companies have been out there promoting that senior pets need a protein-restricted diet. You're saying the opposite, and I agree with you. The literature, the data shows us the opposite seems to be true. But my question is, how do we convince veterinarians? How do veterinarians convince their clients to feed more protein when for decades they've been told to feed less protein for the senior pet? What are the ups and downsides might be a way to look at it. Sorry, your thoughts.
That's a really great question, because that seems to be the big stumbling block. And I think that education has to be part of it, obviously, and sharing information that we have on studies, but that indicate that as animals get older, that they lose muscle mass, and that feeding a higher protein diet can help sustain lean muscle mass. But at the same time, the education has to we have to look at, we're teaching veterinarians that when you have, with aging, you have a change in renal function, you have a change in, liver function, et cetera, even your gastrointestinal digestion. And so initially they go to, with changes in renal function, they go to low protein. They don't really need to be going to low protein, right? They need to be going to lower phosphorus, but they go to low protein. And so I think that is part of the education. And I think that there's got to be education between the healthy aging patient and the aging pet, cat and dog that does have these comorbidities like renal disease or cardiac or liver dysfunction, because that's where the prescription diets come in. And even though there's a lot of them are very low in protein for that, maybe those are situations where we need to start thinking about supplementing specific amino acids to those diets, and do some more research, of course, and see how that helps maintain muscle mass in these older patients that aren't aging in a healthy perspective. I don't know if that really answered your question, but.
I think I can add a bit to this, because this is also a dilemma the human nutrition field is facing, because on the one hand, like the muscle anabolic signals of increasing the branch chain in the protein is very clear. On the other, there's quite good epidemiology data linking too high protein intake with adverse health effects, and largely because the anabolic pathways in the level of liver and IGF-1 secretion can have detrimental effects in other organs. So I think in humans, there's been really a nice study showing there's a tipping point around the age of 60, 65, where you want to be switching, where too high protein too early is definitely not good. So that's the first layer. There's the age component to it, and the second is obviously the amino acid composition, because I think we want to be balancing a bit those different layers of anabolic versus autophagy, like I showed in our results. And there's these techniques developed in a lab in Sydney called nutritional geometry, where they actually model the three triangles of the macronutrient to take a variable like survival or like all the aging variables, and we're seeing quite tipping points to choose between the different endpoints where we have to look at holistically. So yeah, it's all about the timing and the quality, probably.
Good. For you, Dr. Fage, do you believe that your findings on oleuropeins can be linked with the beneficial health effects of a Mediterranean diet?
In part, I mean, oleuropein alone from the diet we've modeled this is probably not sufficient, because isolated we need higher doses. But we're quite interested in exploring polyphenol interaction, because obviously the richness of these diets comes from the diversity and how the different molecules that work in concert sort of synergize and interact. And this is something we're modeling. The assay I've shown, actually the docking sites very molecularly have different binding pockets, and we know you can get synergistic binding. So we're quite interested to explore those additivity effects, to how you can sum them up in the diet.
Great. Is there any research on the effect of dysbiosis on sarcopenia?
Not much.
Not much.
Yeah, I looked a little bit, but there's not much yet.
Okay.
It's just starting, though. I mean, I'm trying to think of the journals that I was looking at, current clinical nutrition and metabolism or something. In humans, they're looking at it, but they're also looking at it from the perspective of frailty as well. And so the emphasis, I think, is a little bit more on frailty than on sarcopenia itself. But I think that it's an area that's interesting and certainly is ripe for some investigation.
Yeah, it will be my next question. Not even humans.
Not much either,
Not
to
much.
be honest. I mean, there's a bit of microbiota transplantation. So people have taken fecal samples from frail individuals versus healthy older individuals, and you can transfer the phenotype. So there's quite good data showing that the microbiome has a causal link, but how to reverse it, how to intervene, I think we're in the very early days.
Okay.
Do I have to turn this on? No? Okay. It's a little bit along that same line of questioning, but I guess from a clinical perspective, often when we're dealing with these elderly animals, they've also got quite advanced dental disease. And I was wondering whether there's been any research trying to connect sarcopenia or frailty and the oral microbiome.
I think so. I mean, we don't really have really strong data yet with, so one important step back is that we need to also understand, when you look at all the publications, literature microbiome, everybody uses different technologies. The sequencing database changes. It's so slowly we have markers that are very reproducible, and with those markers, we can much better compare across studies and so on. And we actually looked at one study. It's not with 80 cats and so on. Actually, we didn't see dysbiosis in old cats, but they all were clinically healthy. So it makes me actually wonder that what you showed the data is that the GI disease is something that starts, and often many cats have subclinical GI disease, meaning before they don't have diarrhea, but they're already having a dysbiosis and so on. And that's the starting point, maybe. Then you have this malnutrition, malabsorption, dysbiosis all together. So I think the GI disease may be one of the very first things that start that you don't really detect very early because it has been there for a long time. But in the end, yes, what we need to do is look at all this together. And I think at the moment, everybody does only cobalamin, only dysbiosis, but nobody does really everything together. And that's the next step.
Anyone else? Do you think that giving cobalamin to all old cats with decreased weight is a good idea? If you cannot, the possibility to measure in every
If you
cat?
can't measure it, absolutely, because it's completely safe, it's inexpensive, and it's easy to do. So absolutely, it's better to measure it, but because if it's low, you need to do it for the rest of the animal's life. And it's not that expensive to measure cobalamin, and many places can do it now. So I think there's actually very little reason for not doing it, but it's a pretty safe thing to do. And if 40% of old cats are going to get cobalamin deficient if they live long enough, it could be a routine thing.
Yes, and
If I can add to this, because we've done a bit of work around this, there's actually different cobalamin isoforms, and there's two enzymes that are B12 dependent, one in the 1-carbon cycle and one in the mitochondria, and we've seen there's quite a difference in efficacy, at least for muscle. Of course, the cell proliferation and DNA synthesis is very important in 1-carbon, but the adenosyl cobalamin form that hits mitochondria has also some profound benefits.
Very interesting. And our last question, still about vitamin supplementation. Vitamin D supplementation in elderly dogs with sarcopenia can be done empirically or only if we identify a deficiency?
I would say identify a deficiency first, but I'm not quite sure how best to do that. That's a nutritionist question.
So just to make sure I understand the question, they're asking, should you just go ahead and supplement with vitamins to the sarcopenic patient?
No, specifically about vitamin D. In elderly dogs.
Oh, vitamin D.
Can I do it from a safe, secure place?
I think the literature that I've reviewed really suggests that you should measure vitamin D. You said vitamin D, right? Vitamin D first before you just arbitrarily start supplementing it.
Should we measure 1-hydroxy D3, or should we measure the fully active D3? Because that's the really important thing, isn't it?
Yes.
So what is the marker molecule that you should be measuring? And in the ideal world, I don't know the answer to that.
I don't think it's determined yet. I think I hear, we can maybe have discussions later on, but I think I hear different opinions and nobody's convinced which one is the right marker. I don't know in humans, which marker is there one?
I think in humans it's well confirmed that also you can only intervene efficiently if you have a deficiency. So that's clear. The trials that went in normal levels largely don't give results. So yeah, the stratification is important.
So what is the gold standard test?
I'm not sure it's completely sorted out between the total and the bioactive. The bone people really go for the bioactive form.
We still have too much to learn.
There's rollout and cost issues as well behind this.
Unfortunately, we don't have more time for questions. We have more questions, but our time is over. Thank you very much for your presence, for your time here, for your insights. Thank you very much all to be here with us in this morning. Now we're going to our lunch break, and we come back at 1:30. Thank you very much.